So I want to start off by thanking our presenters for a very broad range of presentations. We seem to run the spectrum of both product development and the development of new novel vector-based technologies. To some of the problems with on-the-ground implementation of these technologies in terms of operational implementation, some of the solutions that have been proposed for dealing with some of the challenges of operational implementation and surveillance via mobile technologies, and then on the regulatory side, the hurdles in regulation and the challenges that are posed in product development and the balance between efficacy demonstration and safety demonstration. So I also wanted to go back to the first panel discussion and ask that if people have questions or comments for our presenters, if people could just introduce themselves and say their names and their affiliation, so that the presenters know who to respond to, and maybe we can open the floor for any questions.
Paul Reddy, Natural History Museum and London School of Hygiene, Tropical Medicine. I'd just like to congratulate Mentor and Richard Allan for their work in Syria. I was left with no doubt that they've reduced a huge amount of suffering for the population there. I'm less convinced that the vector control efforts actually had any effect. I think it was entirely appropriate that they should carry out vector control ethically and because it might well work. But I'm wondering whether it's possible to bore down into the data that's available so that you look at it not just at a country level, global level, but at a regional, local level to see whether vector control, specific types of vector control, actually reduced or kept down incidence.
Sure. Well, I think it's good to be a skeptic. I think I am too inherently. Do I think the vector control methods work? Yes, to varying extent in varying places. How far they work on a global scale in terms of what we're seeing in Syria, it's really hard to be certain. I think our data tells us, we do a lot of surveys of the communities that receive the prevention tools in terms of, are they used properly? Are they being well perceived? Do they perceive a reduction in biting? And the answer is affirmatively yes on all fronts. Even though we have the same issues about making sure that people use their nets regularly, we don't with IRS. It's extremely popular, it's extremely efficient as a tool in that context to get people protected in the urban environments. Does it control sandflies? Undoubtedly it does, because we're using a range of insecticides rotatingly. So do we think there's any issue with resistance to the rotation? No, we don't. I think the huge problem we face is literally when there is such a mass of vectors, it's overwhelming. So for somebody who's living in Aleppo or Idlib, we can control the vector population to the extent that IRS or NETs can do, and they probably can reduce it to about 60%, or give a 60% protective efficacy as the same way as malaria. The reality is, we don't know because people haven't really studied it to any great degree in the past. And we're working with tools which are all WHO recommended for leishmaniasis control, but without really a big evidence base. So our gut instinct is it's controlling sandflies in their locality, but the sandfly population is so artificially expounded and expanded by the context in the city all around them, it's hard to know if it's enough to really be controlling. I think it is, but I think that's why we're seeing plateauing incidence. I think if we took it away, we would see a rising incidence because we've got increasing vector breeding sites all the time. We're working with 2 universities in Turkey to look at exactly that. But it's complicated from a distance. We're also expanding in Iraq to take an approach from Mosul in the same way. The belief from the health authorities there is that IRS works very efficiently. Again, there's no evidence base. It's about smell and gut reaction, and is it the right thing to do? Morally, it is. I think it'll take us another year or so before we really have the data to say whether or not it's really having a big impact.
So I'll pose a comment, which is that it seems like a lot of the areas that that you're finding in Syria speak to issues of really of surveillance. So how do you appropriately understand how you are targeting diseases in emergency situations, and how do you really do surveillance in an emergency with a population that is mobile and in areas that are so difficult to access. But not only does it speak to surveillance issues, but it also speaks to things like how do you build the evidence base and really understand the efficacy of your tools in those settings, and the need for new tools. And I wonder if maybe the different panel members could all comment on how they feel their particular approach might fit in, both in terms of a general integrated management of vectors, and also specifically in an emergency type of setting or situation. Maybe we can talk with the new vector control tool development first, and then move from that to some of the other.
Well, I think that's something that I didn't mention in my talk, is that the use of this nitisinone drug is not meant to replace any existing vector control measures. It's meant to be used as a complement to existing control measures. It's still in its very early stages, so a lot of things are still being tested out, and safety, efficacy, and its use and applicability in actual field settings, which is in the end the most important thing, that we can take this from the lab to the field. But it does seem to show a lot of promise so far, as long as we get everything in order. Definitely integration of different control methods is the way to go. I think there is a problem in general with communication between authorities within government, with the coordination of the control measures for different diseases. But I also think that there are a lot of tools that are coming out. Many people working on different things that show a lot of promise. So I think there's still a lot of problems, but there's a lot of hope as well.
And, would you like to comment on the mobile platforms?
Yeah.
Surveillance and for emergencies.
Yeah, absolutely. I mean, from a lot of the work, excuse me, a lot of the work that we do is supporting surveillance activities. Typically disease surveillance, at an aggregated level. A lot of our clients are organisations that are deploying malaria programs, for instance. Just thinking off the top of my head, we work with the National Malaria Control Program in Cameroon, and they use the Mango platform to give them weekly updates on stock, anti-malarial commodities down at the health facilities, including nets and artesunate and various ACTs. They also use Mango to collect monthly surveillance data. And you can combine that data then to show disease prevalence and stock, and then start to make informed decisions. And that type of approach can work in stable environments, which Cameroon is largely, although it does have a problem with refugees on one side and Boko Haram up in the north. So it can be quite a challenge. In some parts of the country, it's quite a challenging environment. But because we're using mobile technology, there's not a huge amount needs to be deployed in the field. We support mobile health units, so as Richard was talking about, some units get attacked, so they'll move from one location to another. Well, if you're using mobile technology to conduct your reporting and your surveillance, then obviously the mobile technology moves with them. As long as there's some kind of mobile connection, then your reporting and your monitoring can continue. And one of the upsides of using mobile technology is it's just as attractive to the bad guys as it is to the good guys. So generally speaking, the mobile towers tend to be controlled, and left in operation. So it's not like cutting a landline or something like that. Typically, the mobile technology is available. And some of the countries we've worked in are quite challenging: Chad and Somaliland, and parts of DRC, and as I say, parts of Cameroon. In terms of surveillance, we do a lot of that kind of work, and it's shown to be very effective. In terms of vector control, a lot of the work we do touches on that anyway, with monitoring of net stock levels, and we support net distribution programs. We can issue vouchers for nets if there's a subsidised type program going on. We can support our indoor residual spraying activities. We can conduct, support if there's a pre-IRS census, we can provide the tools on mobile devices to enable the census data to be captured and sent in real time, and we can support the monitoring itself in much the same way as we've shown with the Mass Drug Administration. Monitor the stock levels, and what we also do is enable those data sources to be brought together in a common platform. So even in tricky environments, you can still have a level of visibility over what's going on.
Do you want to say a few words?
Surveillance is a nightmare because it has so many levels to it. It starts with the eyes of the health worker looking at the patient and how they define the disease. We have a thing called standard case definitions, and in Syria they were anything but standard. There were probably 20 different types of case definition for cutaneous leishmaniasis when we began. If you have 20 different types of definition going on in practice, your surveillance is worthless. You first have to start by getting everybody to see the same disease with the same eyes and record it in the same set of definition. And that was our first job in Syria, was to try and get people to do that. Of the 200,000 cases we had reported to us in 2013, I'm sure it was a gross overestimate. I'm sure it was probably more like 120. We've got data from just over a year ago where we were on 110,000 cases. But we had to do a huge amount of work just to get people to use standard case definitions at the clinic level. So they're all seeing and recording the same way. The second is because this sort of disease is a disease, unlike malaria, where you keep coming back to the clinic to be treated. Many people would have been picked up and recorded on the second visit and the third visit as a potentially recorded as a new case. So again, that was something we had to sort out, and that's all to do with the piece of paper you give to somebody to take away, which they present every time they come back to a clinic, which says what they've had before in terms of their treatment, and so what stage they are at the next level of treatment for the next injections. With a situation where both the clinic may have closed down by the time they come back, or they have been displaced to a new area, we had to make a system which would be portable. So wherever they went, the clinics would recognise the same piece of paper and be able to pick up that patient as they moved. Well, we've done that now, but that's taken 2 years to really get into place and to be really then confident about the data. Thereafter, getting that information out is where the electronic information with mobile phones becomes a very, very helpful tool. once you can trust what you can put into the information relay, so that you're sending trustworthy data rather than just garbage, it becomes a really useful tool to get that data out in electronic form, which can be straight uploaded, and alleviate the problems of having to manage manual data and reinsert it again into a computerized system. So for me, there's a very, very important message in all that we do in the field, which is to use the right tool for the right job, but always to remember the different stages of information that go behind that in order to make it valuable and valid. It's a complicated business, but if you strip it back and make it stepwise, it becomes logical, and you've just got to tackle them head on. And it takes a partnership approach to do that. There's never one tool for finding a solution for disease control. There is no magic bullet for malaria. There is no magic bullet for any disease. It takes a toolbox of common sense tools which attack a disease or report a disease and control a disease from multiple angles, and picking the best tools for each context.
I don't know if we want to open this back up to the audience if anybody has any additional comments or questions on the things that we've spoken, and then we still have one person who needs to give their perspective. Yes.
Hi, my name is Aaron Hoyles. I'm with the Breakdown Initiative, and we foster collaboration on integrated approaches to combating data. And just bouncing off of your mention of partnership, I'm just curious for all of the panelists. You are in different areas of research and development, some in application, but there's at some point, it's very obvious in Syria where you're in the field, you have to have some sort of collaboration. Perhaps there are other organizations that you partner with to have access. Perhaps there's some collaboration necessary with telecom or with other researchers working in complementary areas. Can any of you speak to some way in which that's been crucial to some aspect of whether the development phase or an application to the work you've been doing?
Yeah, well, I mean, as far as this century, yeah, I mean, you're right. I mean, we never work alone. When I say we, I mean Greenmash. I mean, we're never a principal recipient. We are, I suppose, what you call in simple terms a subcontractor. So we're like the plumber, if you like, working for the main housing contractor. So our collaboration starts at the program design typically. So if we're working on a bid, say with DFID or USAID or something, and someone will have designed or conceived a program, and they'll be looking for a technology partner to help them achieve the goals of the program. So typically we'll get involved at that stage, so that partnership will start then, and assuming that bid team wins, of which we'll be a member, we then have to start forming partnerships on the ground. So we'll need to partner with local mobile network operators or find a communications partner, an aggregator that can give us a gateway onto those networks. We'll have to form a relationship with the program team, which is quite often, although we'll be working with the same organisations as during the bid stage, we'll probably not see those bid team guys again because they're off to do the next bid. So we'll need to reform those relationships with the same organisations on the ground and explain to them why we're there, get their input into the design of the system. Teach them how it works, explain to them maybe the benefit, go through the whole sales cycle again, quite frankly, in many cases. Speak to the participants, so it's important to get some input from the guys on the ground who are actually going to be providing data, health workers, community health workers and so on. So the whole concept of delivering a solution of any kind is very much a collaborative one.
Technology is really important in the delivery partnership is really important in the delivery of the technology.
Yeah, absolutely. It was, yeah, exactly. It's like Richard was saying, there's no point deploying technology until you've got certain things in place already. So, you need to decide what it is you're going to be doing, what data, standardise those indicators, standardise how you're going to report, make sure everybody's on board with that people aren't going to leave the meeting and go and set up their own different way of operating. So, you need to collaborate, you need to share ideas, get agreement, and then that's when you can start delivering.
And wonder if we could also hear about collaboration and partnerships on the regulatory side, and in terms of really moving the product from a manufacturer industry partner through that process, and then out towards the field as well.
Well, basically, that's what we are doing. We are trying to collaborate not only with our customers, of course, because they need these products authorized, but we see at the moment a real need for collaboration also between different producers of insect repellents in order to come to standard procedures. Obviously, there is no real defined procedure available, at least in the EU at the moment, and we see that this is causing a lot of trouble. So basically, there is still a lot of homework to be done, and this is something which not one company should be able to do, because we need this then for all the different actives. So that's where we're slowly now finding our way towards a collaboration.
So I think we may need to continue this offline over coffee break, but as it is now time, we're slightly over time for the coffee break. But are there any short last-minute words from our presenters as a take-home message? Maybe a single sentence?
I'm not very good at single sentences. How long have we got? You better go first.
Well, just to say, we're an unusual NGO in many ways, because we think that new tools are the way forward, because the old tools we have are continuously challenged, because insects are brighter than we are. They get wind of the tool very quickly, they get wise to the tool rapidly after that, and the need for new tools to feed the ability to control disease becomes a constant chase. So collaboration for us is a constant ongoing process with commercial companies who make tools, us helping to define for them the context in which the tools they have the capacity to make need to operate, and finding platforms in which we can help them evaluate those tools when they're actually on the ground being used. And then taking the best of that technology and making it usable in emergency settings. For us, it's lifeblood. So collaboration, collaboration, collaboration.
Yeah, maybe a word from my side. I would like to see in the future that people do not start calculating worst case over worst case over worst case, but take a step back and then look at what repellents are for, in this case repellents, and think about how the praxis looks like in order to come back to reality and then also see the benefit of these products.
Well, I completely agree that novel vector control tools are the way forward. I think that they often come from places you don't expect them to, like just studying the physiology of an insect, and this is how the discovery of this drug was made. Hopefully funders will keep this in mind. Funding science and research at all levels, it has its benefits.
I'll just finish off. So, trying to think how can I keep you short, but informed decision making. Really, that's what we're here to support. Taking action based on data, so we can help get the data. We've got a lot of experience in helping people design how to get the data really effectively. So if you know what it is you need to collect, we can help you get it and put it forward in a digestible way that supports informed decision making, which hopefully leads to effective program deployment. One sentence.
Fantastic. So with that, I'd like to very much thank our panelists for giving us a very broad overview of vector control innovation space from product development to regulation. And I'm sure that people will want to approach everyone over coffee break to ask any more pressing questions.